Hey guys, Dr. Dilip here. And first of all, good evening to everyone. And today marks a kind of a milestone in the journey of conceptual medicine, and indeed a very, very proud moment for every learner under this banner. With immense pride and privilege, we welcome Dr. Professor Narinderpal Singh, sir, a name that resonates with excellence, leadership, and legacy in internal medicine and, of course, nephrology. From the classrooms of MAMC to the corridors of Max Healthcare, from guiding DNB programs across India to representing India at the World Congress of Nephrology, Dr. Singh has worn many, many hats as an educator, mentor, a researcher, and a clinician par excellence. With over 250 plus publications, which I couldn't imagine at all, I mean, how he really did that, and with a H index of 42, guys, and various editorial positions in leading journals, including JAPI. He has shaped the academic foundations of thousands. His contributions to hypertension, point of care ultrasound, and clinical reasoning have become national standards so far. Dr. Singh's vision aligns perfectly with conceptual medicine. For that matters, he is here to make the clinical thinking accessible, to promote evidence-backed management, and to nurture a culture of mentorship and innovation for students and residents and early career physicians across India, especially those who are working in the resource limited settings. As the Dean of Research at Eternal University and National Vice President of the API, he carries both scientific authority and, of course, a mentor's heart. So today, conceptual medicine gains not just a mentor, but whom I would like to call a movement builder. Welcome, sir.
Thank you, Dilip, for those kind words. I don't know whether I deserve them or not, uh,
If you
but
don't
uh,
deserve, no one will, sir.
thank you, Dilip. Thank you so much. And hi, residents, hi, trainees. It's a pleasure and honor to be a part of conceptual medicine to empower you what I learned in last 4 decades or so. Thank you.
Thank you so much, sir. Thank you so much for accepting our invitation to be a part of conceptual medicine. And we missed Dr. Apu, sir. So, who is the vision
Yeah,
and the mission
we
behind
have
all of this? I mean, in the e-conceptual
been very
program.
lucky. Yeah.
Yes, sir. Yes, sir.
Apurv had been my student, and now I am reporting to him. It's always a pleasure and a honor to be a part of conceptual medicine. And thank you, Apurva, and thank you, Dilip, for taking me on board.
We see like Apu, sir, as a kind of a big boss for all of us. So, I've been one of his students. And it's so heartening to see that there are like three generation of people sitting and talking. So
Yeah,
you, Apur sir, and me, who's Apur sir's student. So maybe you can treat me like your son or a grandson, probably, sir. So that's how it is.
you are right. Thank
So,
you.
sir, we can have some quick question answer discussion with you.
Sure,
So if you don't mind, so that it will help our residents to understand like what we are really, really trying to do.
sure.
Yeah. So first, sir, you have taught across premier institutes for nearly 4 decades now. And what do you feel the residents in India lack the most as of now?
I think it's a very, very pertinent question about, what is the state of education, postgraduate education? Uh, you know, uh, Basically, we have evolved and we have changed from clinical medicine to a MCQ based medicine. Most of the time of the residents is spent on, trying to mug up questions or solve those questions, which will have some theoretical bearing, but that art of, patient care, that art of healing touch, probably has gone over a period of time or years. From clinical medicine, we have evolved to investigative medicine, and it is more and more MRIs and angiographies rather than trying to understand the patient also. This is what my uh, thinking is about how last 4 decades have changed the medical education.
Absolutely, sir. I've heard a lot of people, my older people also used to say, my teachers used to say that people always know the guidelines, but they always struggle to make that layered decision making.
Absolutely.
That's why conceptual medicine is here, which is kind of poised to solve and decode, like not just how to think and to apply it in clinical practice. That's why we are here.
So
And
if I have to actually give you a concept of conceptual medicine, which I learned over last 2 weeks, is actually, it's it for me, it's a return to the soul of clinical medicine. What you guys are doing is not only, root call, recall is not your main purpose. It is like understanding. It is not memorizing. It's like internalizing rather than just allowing then decisions to flow rather than actually rote recall. That's what I understood about conceptual medicine in last 2 weeks, which I've been dealing with here.
thank you so much, sir. And in your view, what do you think is the biggest challenge for medicine residents who are outside the metro cities?
I think it's again a very, very important question because there is a huge gap of education. Unlike Western countries, where the standard of education is same throughout the country, but here, the moment you step out of NCR or step out of Chennai, you'll find that the standard dips down. Though the National Medical Commission and National Board are ensuring that there is a uniform medicine. But then in the resource limited areas, in the rural areas, one is that we lack clinical patients. Second is we lack good experienced clinicians or teachers who can impart them what is their experience. Ultimately, they are left to learn from their books and learn from those postgraduate, these last four years, a lot of entities have come up which are imparting this online education. Unlike conceptual education, medicine, these are, just making them so-called memorize things rather than actually making them understand. So this is what has been the difference, and I feel your concept is actually will definitely impart the deficiencies which the rural residents are facing.
Absolutely,
So
sir.
it
People think it's only about the infrastructure, but I feel it's more of a consistent mentorship that people lack outside, like what you say in the metro cities.
Absolutely. I think probably, if I have to give them my viewpoint about, so within this so-called limited times, we need to provide them with clinical reasonings. We need to provide them case-based, discussions or trying to pathophysiology based, and so they need to learn to apply, not just to, absorb. They have to understand the concepts and then they can apply it on their patients because the basic principles remain the same of clinical medicine.
Perfect, sir. And as someone who has been a national coordinator for DNB medicine, what are the gaps that you see in postgraduate training, sir, that too in India?
As I said, I think the uniform standardization of medical education is still a long way to go in India. Uh, you see, I've had an experience of working in a medical school, in a private university, and also in a corporate hospital. The focus is different. The principal, principal objective is to earn money or to, have more numbers of postgraduates coming in. So a structured, reasonable, and a approach-based learning is not there. So most of the times in private institutions, they hire teachers who come once a week, teach them theory subjects, and then go away. I, for one, and feel and understand that it should more be learning from our students rather than giving them knowledge. That is, I would rather speak less in the class and let my students speak more. So unfortunately, in the DNB and if you look at the questions also, I don't want to go into details, but they're all theoretical based. They're not patient oriented. So all over the world now, the understanding has been from sort of a evidence-based medicine to patient-centric approach to individualized medicine to precision medicine. So there's a huge gap as of now, but I am very sure over a period of few years now things might change. This new education policy has come about. I i understand that at least in the basic subjects, not in the medical subjects but in the basic university subjects, things are changing. So I have a great faith that education in India is going to have a significant change and will impact and will it line with the international guidelines.
Absolutely, sir. We are actually producing more textbook doctors than decision
Yeah,
makers.
absolutely, absolutely.
And that's why we have conceptual medicine, so that we can make the students learn in an active case-based learning manner. So that's what we are trying to bring into the table.
So I think what I will add here is we should differentiate between the two Bs. Now I always tell them about one is Boston and one is Bihar. So we read Harrison or we read books which are entirely based on Western experiences. So I think probably I feel that I will call you CM rather than conceptual medicine always. So essentially, our CM promotes Indian contextual learning. What is happening in a young male in Bihar with 2 weeks fever may not be the same which is being taught in Boston. So our teaching should mirror our own medicine, right? Rather than that is why I think it is very important to understand our patients, our epidemiology, and then teach them to become a good doctors who can practice in our rural areas.
Absolutely, sir. And you have achieved almost everything, sir. I mean, that internal medicine resident or physician can dream of. But why did you choose to collaborate with conceptual medicine at this stage of your career?
Oh, in fact, if I have to tell you my story, it will be quite a lot of time, but suffice it to say that my passion for last 5 decades. In fact, I started teaching at the age of when I was in sixth standard. Don't ask me why. So my passion is teaching and empowerment. If I teach one student, he's going to empower 10 or 20 or 100 more. As you said, there's a three generation now. I loved being in a very, very prestigious medical school in Delhi, Malaz Medical College. And my second goal was to become a teacher. And God was very kind to me, and I became a teacher. I was there for 10 years. And when I joined corporate, the uh, first thing which I told them was I would like to start academics here. And within, you won't believe that we started with four students. At present, that institution where I taught for 10 years has more than 100 DNB students. So my passion is to teach, to empower. I, I, I. That is why for last 4 years I've been coordinating the teaching of internal medicine through National Board. So I would, and conceptual medicine for me was like it was like it is just gelled with my ideas. So you have also been teaching. It was only that I was talking to one of my colleagues from medical school, and he gave me this. He told me about the concept, and then Dr. Apurva was very kind to invite me, and that is how I joined. And I'm looking forward to a very fruitful and a good collaborative understanding between not only other faculty members but also with my dear students whom I always feel that what a good teacher is what a good student would convey or give him. So if I am called as a good teacher, it's all because I had good students who backed me and who questioned me. That is how I have come to this position as of now today.
You're so humble, sir. We have to learn a lot. And what be your advice to a first year resident who tends to feel a bit lost and overwhelmed because of the work that do in Indian medical colleges?
So I think if you look at the the profile of a first year postgraduate who has been given almost a bookish knowledge in 4.5 years in medical school, and then he joins these coaching center. I don't want to name any one of them. There, the concept is MCQ based, MCQ based, and MCQ based. So the moment he joins a medical college or a DNB institution, he faces the real world. He faces the challenge of confronting or seeing a sick patient. And in our frame of education, that he might have actually got some theoretical knowledge, but the understanding, the practice, and the soft skills like empathy, compassion, communication skills for that matter, are strangely and unfortunately lacking in our first year resident. So I think probably we need to bridge this gap and trying to make them understand the concept rather than ratifying the disease. Uh, Lately I've been reading a lot of preclinical subjects, and it has changed so tremendously. There's so much of genetics, so much of disease-based mechanisms have come out that if I have to impart the same to my students, they will be much more confident in managing patients. So, we have over prioritized protocols and guidelines, but actually, these things will not let a resident do his own thinking. Actually, if I have to tell you, clinical reasoning is actually harder to teach and test. So it's the
Absolutely.
core of safe and adaptive practice, especially talking about complex and atypical cases. So I think every day is a challenge. I would love my first year resident to take up this challenge and keep on learning and sharing.
And now it's a time for controversial questions. Do you think clinical acumen can still outperform technology in the modern era?
I think a very, very pertinent question. I think, today, if I have to tell you, uh, we were earlier, and when I'm talking about I'm talking about a physician, a caregiver, and the care seeker patient. They are relying heavily on, you know, technology, and you know how AI has now lately for last 2 years dominated our clinical practice. So, but technology will definitely aid, but technology will not teach you empathy, the pattern recognition. You know, uh, how I understand is the first patient which comes to me, and if the second patient comes to me of the same disease, there is a pattern now. Way long time back in India, we had epidemic dropsy. And just to share with you, I was among one of the first to have declared that there is an epidemic dropsy
Wow.
because I got two patients with swelling feet from the same compartment complex. So pattern recognition, feeling the collapsing pulse of a patient with an aortic regurgitation, that comes from bedside. So that cannot be taught by technology. So definitely, I think we need to. It's not that technology does not help us; it helps us. We need to imbibe from them, but we need to take our own decision. It will be like making them. I won't call them as servants, but making them, you know, support us rather than entirely, implementing what they guide us. So I still feel clinical medicine is
Absolutely.
not only challenging, it's beautiful. Just giving you one example where a lady, 45-year-old, a Jan lady, came to me with low-grade fever, a PU of 4 weeks, 5 weeks, and the only clue she had was a backache, mild backache. And if I have to convey what diagnosis we could make just on the clinical reasoning, turned out to be a dissection of aorta. So, what I'm trying to say is that it's a challenge. We have to keep on asking questions to us. It is not that, And yes, technology like ChatGPT will help us now, but we have to read it. We have to see whether it is fitting into our patient or not.
As Dr. William Osler said, you should be willing to see it first.
Yeah, yeah, absolutely, absolutely. I agree with you. They were great clinicians at their times because there was no technology. So I still remember by looking at the pulse in one of the very old movies, he had said that your daughter is pregnant. So what I'm trying to say is that they had that clinical acumen to come to a reasonable judgment just on the basis of a good history and a physical exam.
Both should go hand in hand, sir. That's why we are here. So we are not only here to give you a good clinical acumen, we are here to provide the technology-based advancements as well, so that both goes hand in
Yes,
hand.
which is
That's going to shape into a good clinician.
so what I will just add in fact what mistake did I do in last 4 decades had been when the patient comes to me, I do a good history taking, and occasionally when I'm in a rush, that physical examination part many a times is lacking. A patient who comes to you with an acute breathlessness can have various causes, and unless you get up, percuss a patient and make a diagnosis of pleural effusion, you will miss that. So finally, X-ray will help you. So I would always expect my residents to have take a good to seek a good history, but also do a physical exam. Unfortunately, post-COVID, technology, this physical exam is becoming is shrinking a lot. But there is an importance of physical examination. That is what I did a mistake, and I would like my residents to emphasize both on history, physical exam, and then investigation. And technology will help us in all the three. Yes, Dilip.
Yes, sir. So I used to quote this to my residents as well. Like, for example, any investigation you take, like ultrasound or CT or MRI, so it just going to bring you maybe a few inches to the patient, not very close to the patient.
Absolutely.
Nothing more than that. Anyway, sir. So if you just had 1 year to shape a doctor, what habits would you like to instill in them first?
I think a very, very important topic and very, very important question which you asked me. I would suggest that 1 year is a short time. It takes lifelong for you to be a good human being and a physician. But still, within that year, I would try to empower him to ask questions, to ask why this, why that. You know, apart from the theoretical reading, I would like him to interact with the patients, ask questions during the rounds. I can tell you the amount of, recall memory which one gets during those rounds can be much better than reading so many books. So I will expose him to as many patients as possible. And also, I would like him to interact with the patients in view in a reason of trying to impart communication skills, which unfortunately in our system of medicine is much, much lacking. Both communication skills and ethics about how we should behave with our patients and how we should maintain their confidentiality and consenting process. All these are pretty important for me to take. And of course, standard teaching, 1 or 2 hours of daily standard teaching, focusing them and motivating them in trying to do their self-learning when they go back to their hostels or rooms. But come back with that theoretical learning to answer or to question many of us. That is how our knowledge will improve, and we will, within a year, I will be able to impart some sort of semblance to a hungry first year resident. But having said that, as I am saying, even after 45 years of a very, very hardworking, sincere clinical medicine, I still get challenged, and I happen to see many more patients which I had not seen them in, or at least not diagnosed them in last 4 decades or so. So it's a continuous learning process. But within a year, I will definitely like them to prioritize concept, clinical reasoning, case-based discussions, and learn how to apply, not to absorb.
One final question, sir. What one mindset shift do you think could transform an average resident into an exceptional clinician?
I think probably I may be, I may have a different viewpoint, but my understanding is be patient-centric, have empathy, have compassion, and be a good listener. Now, if you are not a good listener, you will not be able to understand not only the medical history which the person is giving you, but also uh, not understand the social dynamics, socio-economic dynamics, and what is the patient's preference. So be a good listener, be empathetic, have a compassion, plus have a scientific knowledge. So both science and art is what makes a good doctor. Have theoretical knowledge, but learn to apply it to your patients in addition to the soft skills which one tends to imbibe through their teachers or seniors.
Absolutely, sir. And thank you so much for spending your valuable time on for our residents right now. So, and I think whatever insights you have given, well, like really said, I mean, it has to be taken. I mean, I'm actually literally sitting and enjoying like whatever you're saying, because this is what like every teacher of mine used to say, and this is what has been propagated generations after generations. And if they are
So
going to listen to you, like they're going to become exceptional clinicians for sure.
thank you, Dilip, and your questions were very, very thought-provoking, and they were very, very, reasoning questions, and which are the demand of today's world, that we need to have such understanding and such gap, bridging the gap of what a resident and a medical schools are doing. So I'm very sure conceptual medicine has an excellent future in terms of next 5 years. I would say that you you will be, you know, there's always a era. There was an era of telephone, there was an era of mobile phones, there was an era of Google, and now there's. So I think the next 5 years, we're going to see concepts of conceptual medicine being practiced by most of the residents, where who find these things not available or neglected, but not being imparted to them in the medical schools. So thank you very much, Dilip, for
Thank
taking
you
me
so much,
over
sir.
and
And
wrapping.
sorry that I missed that you have written a lot of books. One of my favorite books so far is your Oskies in Medicine. I'm talking from a resident's perspective. So that was one of the excellent books that you have written. Apart from that, of course, for even for specialists in nephrology, you have written a couple of books.
So I plan to come out with the second volume of this OSCE book, and I would rather, rather than my writing a book, I would tell my students to let us all combine and let us talk about certain cases which you feel are very rare cases, and I will convert them into OSCE and we will come out. It's a continuous process. Thank you very much. My passion is nowadays, with some time which I have, to write books so that I am able to impart
Yes, sir.
practical
The
knowledge to.
edition comes,
As
I'll
you
be the
said,
first person to get it and read
yeah, thank you.
Oskies.
Yes,
And
OSCEs are now a very important component in DNB medicine. One paper is on OSCE. So I would definitely, I had one recorded a lecture on OSCE, but I am planning to have many more OSCE lectures.
thank you so much, sir. We'll be associating in a lot of things. So we are planning to do a lot more in the upcoming year. So we are planning to start the live sessions on Doctor's Day on July 1.
But it was wonderful interacting with you, though I had prepared some answers, but it all went off and we just had a spontaneous chit chat. Nice.
Yes, sir. Sir. I feel like the spontaneous chat was much better
Yeah, yeah.
and you
So,
nailed all the points. And thank you so much, sir, for your valuable time. And I know you have another meeting scheduled in the next 15 minutes, so I don't want to take a lot of time. And I have a lot more questions to ask. I think we can discuss maybe on some other day when you're free. And thank you so much.
thank you, Dilip, and thank you, Conceptual Medicine. And let me take this opportunity to thank Professor Dal, who started this journey for me, and of course, Dr. Apurva, who readily agreed to take me over. And thank you, Dilip. In fact, I have learned in today's interaction much more from you than what my experience
Oh,
is,
sir.
and I'm looking forward to a very,
You
very
are like kind of a
fruitful.
fatherly figure to all of us. So thank you so much, sir. Thank you so much.
Have a good night. Thank
You
you.
too, sir. Thank you, sir. Thank you, sir. So, guys, let us thank Narinderpal Singh, sir, for accepting our invitation and being a part of conceptual medicine. As I've been saying, he's not just going to be a mentor, he's going to be a moment builder for us. And with all his experience, with all his might, with all his knowledge, we're not just going to learn clinical medicine, we're going to learn the advances and we're going to learn the empathy, sympathy, and the clinical humility, which I always call it. And that's what is going to make an exceptional clinician. And thank you so much, guys, for being with us and see you all soon. As I said, our live classes are going to resume by July 1 on the Doctor's Day. And we are going to anyway continue with the recorded versions also. And there are lots of things that are going to be starting from July 1. And we are going to be with you and stay tuned. And a lot of things are going to come up. Stay tuned. Thank you so much.